Yeah,
Okay, hey everyone. Welcome to the first session of RADMASTERS. This is going to be me, Dr. Dev, and Nikhil, and we're both, as you know, very enthusiastic educators online, and we've both qualified the FRCRs, and we got together and decided to, do something so that we can help anyone else who finds themselves in a bit of trouble when they're going through the Viva, because, back home in India, and we don't do the Viva like this, which is very different from the way they do it in the UK. And so we thought maybe we would be able to create some value for me. There are other people doing it, but we want to do it with our own method, our own process, and see how it goes. So Nikhil, why don't you say something?
yeah, I think that's what I would also like to say. I felt a lot of courses don't go into depth of how could you approach each cases and how should you be talking in situations where you really do not know what is happening with the case and you are in a confused state. So basically, we are trying to approach the whole session in that angle and kind of break the ice, and so that you don't really look at these cases as an exam case, but more of an interaction thing, and you have an idea how to approach cases in general. Yeah.
Yeah, I mean, I think many of us have felt that after the exam, we've come out feeling that this was much more of a discussion than, a viva like we would expect. I mean, I don't know everyone else's experience. Everyone has a kind of different experience, but I felt that the examiners were talking to me much more than I thought they would. So, I mean, we'll just try to recreate the feeling that we had, and maybe prepare you for that more than we had the opportunity to.
Yep, precisely. Yeah. So once we have done with that, I think without further delay, I think we can go ahead with the first
Yeah, yeah,
candidate.
yeah.
Yeah.
Absolutely. Let's get to it. Yeah.
Yeah. Okay. So candidate A, are you audible to me?
Yes, I can hear you.
Yeah, great. Okay. So you will have first 15 minutes with me. Dr. Dev would be marking you, and then you will have 15 minutes with him, and then we'll go into the feedback. Okay.
All right.
Great. So just give me a moment.
So while Nikhil does that, I'll just let you know that we'll both be marking you for each of the Viva, and that's the way it works. And you'll get feedback from both of us for both the examiners.
All right.
Right. Okay. So just give me a moment.
I just request everyone to kindly mute themselves except for candidate A and the examiners, please.
Okay. So this is your first case, and your timer starts now. You can start.
Okay.
Just a moment. There's a lot of feedback. I think someone has their mic on that might interfere with the process. Nikhil, can you just
Yeah, I'll
answer
just
that?
one sec. I'll just mute them one sec.
Yeah. Yeah.
Okay.
Yeah, please go ahead. Please go ahead.
Yeah. Provided with a frontal chest radiograph of an adult. And I can see first thing which is apparent to me is that there are multiple sternal wires in situ, which suggests that the patient has had a recent surgery. I'm looking at the lung fields for any obvious lesions. I'm unable to see any obvious lesions in both the lung fields. I'm looking at the bones. The bones appear grossly normal. I'm looking at my review areas. I can see that there is a retrocardiac opacity, which is seen behind the left heart border. I can see that there are some external chest leads as well. I'm not seeing any free air under the diaphragm. You can see the stomach bubble. So in my routine practice, I can also see that there's mild widening of the left paratracheal stripe. So in this current scenario, where the patient has probably had some kind of surgery, probably I'm thinking of maybe a post-op complication, maybe a hematoma, as one of the first probabilities here. And in my routine practice, I would ask for the history of what kind of surgery the patient underwent, and I would review the previous pre-op radiographs if available. And I would also look at a lateral view if available, and then take this case further for cross-sectional imaging with a CT angiogram if possible.
Would you ask for control and show me the opacity that you were describing?
Okay, one second.
Yeah, you can.
Okay, is my mouse visible?
Yes, yes, yes.
Yeah, probably this stripe looks a bit more widened,
Okay.
and this retrocardiac, probably that is an enlarged chamber rather than a mediastinal lesion here. And I'm not seeing any other obvious. I can see some rib changes here, probably that's secondary to the surgery
Right.
along the lateral aspect. I'm not seeing any pneumothorax, no pleural effusion, no massively enlarged heart. So since there is a history of surgery, I would get probably clinical details regarding the same.
Correct.
And ask the patient's current clinical status.
So if you were to assume that, this is an opacity, if this is an opacity, where would you place it? Would you think, is it from the heart or from anywhere else?
This could be a mediastinal lesion,
So
and it would be more anterior because I can see the descending thoracic aorta quite clearly behind that.
Okay.
So the anterior middle mediastinum probably would be where I would localize it.
Okay. Okay. So you asked for a lateral radiograph. We have a lateral radiograph. Do you want to comment on this?
Okay. Provided with the lateral radiograph of the same patient, I can see that there is a well-defined lesion which is there in the anterior to middle mediastinum. It's showing a thin border is overlying the cardiac shadow. So so this is quite anteriorly located. So one of my differentials in this case would be like probably pericardial cyst, or another would be, I'm not seeing any obvious internal calcifications or any fluid levels.
Okay.
So pericardial cyst comes to mind, probably a duplication cyst of some sort.
Arising from where?
Probably from one of the airways, because an esophageal duplication cyst would be quite posterior.
Yeah, the location does
So
not fit with that.
does not fit with a
Yeah, yeah.
duplication cyst.
Okay.
So I would probably evaluate this further with cross-sectional imaging.
You give me just one differential. Could you think of some more?
Yeah, pericardial cyst. Then if it's a cardiac surgery, it could be like a calcified aneurysm.
Okay.
Post, if it's an MI,
Okay.
it could be like a LV. It could be like a eccentrically expanded left ventricle
Aneurysm. Okay.
aneurysm. Yeah, calcified with some kind of
So,
calcified.
since you spoke about aneurysm, what are the types of aneurysm that you know of if it was in left ventricular aneurysm?
One would be like if it happens like post MI, we can have a LV aneurysm,
Right.
which is like which is I think a true. It's like a false aneurysm, I believe.
Yeah. Okay. So my question comes down to, how do you differentiate between a true and a false left ventricular aneurysm?
Uh, True and a false left ventricular aneurysm. Uh, Probably a true aneurysm would be involving all the walls of the left
Okay.
ventricle.
Okay.
Probably echo might help for further evaluation.
Okay. What about the neck? Do you know any difference based on size
Neck,
of neck?
I'm not very sure. Probably they'll have a narrow neck, the false ones.
Okay.
I'm not sure. I'm not sure about how to
Okay.
differentiate.
Okay. Anything else that you can think of?
Hydatid cyst is possible, but unlikely in this clinical scenario.
Mm-hmm.
I would ask for history of travel to
Right.
areas.
Okay. Okay. So you said you would go with the cross-sectional CT. So we have CT for you. You can click and scroll.
Okay. Okay. Yeah. Provided with CT contrast, and I can see that straight away that there is a peripherally thrombosed aneurysm, which is rising from the junction of the right atrium and the right ventricle. I'm trying to look for any connection with, and I can see that I would just like to scroll through all the images before I come in further. I can see the aorta. It's very close to the aorta as well. I can see the right coronary artery. Okay, so this is a dilatation of the right coronary artery. There's a right coronary artery aneurysm with an eccentric thrombus here.
Okay.
And this is an urgent finding, and I would convey these findings immediately to the referring clinician and get the interventional cardiology team involved
Okay.
for this patient, as this could lead to a fatal outcome if not treated promptly.
Okay.
And rest of the vessels look fine. I don't see any filling defects within the aorta or the coronary artery,
Okay.
nor do I see any thrombi within the ventricles or the atria to the extent visualized.
Okay. Okay. So you tell me this is coronary artery aneurysm. What do you think the possible etiology would be, considering the age of the patient?
It could be iatrogenic, possibly the patient had some form of stenting,
Mm-hmm.
and or maybe grafting, bypass grafting.
Okay.
So it could be iatrogenic in this case.
Okay. Okay. Anything else? If it was pediatric?
A pediatric, probably Kawasaki's
Mm-hmm. And
disease.
if I tell you if it's a person who is found on the roadside, a homeless guy, what would you think of?
Probably some form of drug abuse.
Mm-hmm.
Would
Which
be like
drug?
a mycotic pseudoaneurysm.
Yeah, mycotic. So what?
IV drug abuse with mycotic pseudoaneurysm.
So what other infections? Why mycotic? If when you're thinking of mycotic, what infection comes to your mind?
Streptococci.
Mm-hmm. Anything else in
Uh,
STD disease?
Klebsiella. I'm not sure about any other organism.
Okay, okay. And anything else? Any other conditions that you know that can be associated with coronary artery aneurysm?
Coronary artery aneurysms. Maybe aberrant causes can be associated with aneurysms. Alcapas
Right,
or
right,
aberrant
right,
causes
right.
can be associated with.
Okay, okay. So if I tell you, how do you differentiate from coronary artery ectasia?
Aneurysm by definition should be at least 1.5 times the parent vessel size.
Okay.
So ectasia may not reach that dimensions
Mm-hmm.
generally.
Okay.
I don't know specifically in the case of coronary arteries, I'm not sure, but generally, and ectasias are less prone to uh, thrombosis as compared to aneurysms and complications.
Okay. Okay. Great. We'll go to the next case.
Just a reminder, last 5 minutes left.
Sure.
Okay.
Sure. Yeah. Yeah.
Provided with frontal chest radiograph of a adult lady, and I can see that there is an implant which is there on the right side, which suggests that the patient has had a mastectomy in the past. Uh, uh, and I'm looking closely at both the lung fields, so for any abnormality, and I can see that in the uh, right hilar region there is some well-defined opacity, reticular opacities, and there is some haziness. Rest of the lung fields appear grossly normal. The bones appear grossly normal. Uh, so and yeah, so in this case, of a patient who has had probably surgery, uh, I would be strongly suspecting some form of recurrence or
मैं जोर से नहीं दबाता हूँ, दर्द हो जाएगा तुमको।
and I would suggest some form of cross-sectional imaging.
Yeah,
to-
just can you pause for one moment? I think we can hear a background noise. I'll just mute that camera.
ये बाल आया था अंदर आज।
I request everybody to stay muted because it's difficult for the candidate to present the case. Yeah, please continue.
Yeah, so probably I would suggest some form of cross-sectional imaging to evaluate this right hilar opacity further to exclude the pause. And also I can see that the left lung apex is also a bit hazy as compared to the right. So I would evaluate both these with some form of cross-sectional imaging to exclude the possibility of recurrence or
Right. So you're telling me this is implant, is it?
that's what I think it is.
Yeah. What about this?
That. Okay, so yeah, I would like to retract my statement. I can see that the left hard border is not clearly visible in this case. So this probably is a left ventricular aneurysm. If that is the case, since the left hard border is not clearly seen.
No, I think let's not deviate from the fact that you think about breast implants.
Okay.
You were.
Oh, probably the other right-sided implant is collapsed, and
Okay.
it is.
Anything else apart from the implant that you can notice?
I can see that there is some kind of the trachea seems to be narrowed.
Okay.
Approximately just before the carina.
Okay.
And there is probably a stent placed there.
Okay.
I can see some form of opacity there, which is lining the walls. So probably this is stent. So trying to combine both, probably I would ask for clinical history in this case, if there was any surgery or any procedure which was done for the trachea or
anything else? Anything else that you can see apart from that?
Apart from that, I can't make out any other obvious abnormality.
Okay.
Anywhere else. Oh, okay. So there is some opacity which is I can't see the fundic gas shadow.
Okay.
So this is probably an abdominal situs is reversed here. And but the marker is on the left. So probably the thoracic situs is there's a right-sided aortic arch.
Okay.
And probably the abdominal situs is reversed here with with the breast implant and some probably implant in the trachea as well. So
okay. Okay, let's go to the next case.
Okay, provided with radiograph of the left humerus.
I think I can zoom to you for a better. Yeah, you can.
Yeah, provided with radiograph of the left humerus in an adult. And the most, I can see that there is again, externally there is some clip and a line which is seen overlying the chest. So probably some procedure have been done for the patient. The bone itself seems to be an ill-defined, and there is a lesion, probable lesion in the diaphysis with a wide zone of transition.
Okay, can you use your mouse and show to me?
Probably this region is a bit expanded.
I think you can click and show it to me once.
Is it visible now?
No, you can ignore that. You can ignore that. Anything else that you're seeing?
Okay. I can see that there is a lot of findings outside the bone, probably in the soft tissue in the chest.
Ignore the chest. Focus on the bone. Anything else that you can see in the bone?
I'm looking closely at the cortices and trying to look for any fractures or any obvious lesions. I can see that there is a linear radio density in the distal diaphysis.
Okay.
And I can't see any obvious, the fat planes surrounding that appear normal.
Okay.
I don't see any lucency around that.
Okay.
It's a linear.
So
I'm not
if
sure
you-
what.
Just give me a moment. Just give me a moment. Yeah. Yeah. Go ahead, please.
Yeah. So I can see that there is that linear radio density in the mid to distal diaphysis.
So what do you think?
I don't see any other similar lesions anywhere else. So I would see a lateral view as well normally before
Right. I'll
commenting
just
further.
give you, yeah, I'll just give you 1 minute. You can quickly look at this lateral and yeah.
Okay. Yeah. So in the lateral view, it's clear that the lesion is in the subcutaneous tissue of the arm anteriorly. So probably I'd ask for history of any foreign body, any kind of trauma, or if there's any, this could be a needle which is stuck, and if I'll ask for history of drug abuse. If it's a young
This was a female
person.
patient. This was a female patient and no history of young patient of reproductive age with no history of trauma.
Okay. No history of trauma or drug abuse, then probably some kind of implant in the subcutaneous plane, some
What?
drug-eluting implants.
Okay.
Uh,
Could you
or
could you connect
or
and probably tell me what could it be probably?
reproductive age group could be some hormonal implants.
Okay. So your
I'm
time is
not
up.
sure.
Yeah, no problem. No problem. Thank you. Your time is up. Dave will take over. I'll just stop sharing my screen. Dave, you can take over.
Okay. Give me one moment, please. Just I can share my screen, right?
Yeah, I've. You can share your screen.
Okay, give me one moment. Just get it out of the way. So share screen. It says the host is disabled, so you need to enable Midro.
Please go ahead.
Okay, thank you. Yep.
Treatment shortage involve the main vitamins को to the sun, sunlight में ना जाए. Sun avoidance करनी
Can you please mute
ड्रग को जो है
Nikhil?
स्टॉप करना है, उसको टॉपिक स्टेरॉइड्स एंटीहिस्टामिन चार चीजें करनी है. अगर एक्शन जो है ना.
Yeah, so that's kind of tends to become a bit distracting when that happens. So is the screen visible?
Yes.
So you can start.
Okay.
I'll just quickly set the timer. Yeah, go ahead.
Yeah. Provided with frontal chest radiograph of an adult, and the most apparent finding is that of ill-defined opacity in the right lower lung zone, which is obscuring the right margins of the right hemidiaphragm, and also both the hila appear bulky. I'm looking for any other similar lesions in the rest of the lung fields. I don't see any. I'm looking at the bones. The bones appear grossly normal, although the lower ribs are not very well
That's okay.
defined. The posterior
You
ribs,
don't have to worry about that.
not
Yeah.
clearly visualized. In my routine practice, I would ask for the clinical history of the patient, if the patient is acutely ill, or if there's any, what is the occupation of the patient. And I would ask for previous radiographs to see if this is something which is a worsening condition, or whether there's a primary radiograph of the patient.
So this patient presented acutely with fever and cough. There are no previous radiographs. First time the patient presented to the hospital, and there's no significant occupational history.
Okay. So this being the primary radiograph and the patient being acutely ill, my first differential would be that of pneumonia, acute pneumonia, probably bacterial in origin. And in my routine practice, I would probably I will convey these findings to the referent clinician and probably discuss this with them, and probably plan for further cross-sectional imaging with the CT chest if possible.
Do you routinely advise cross-sectional imaging for all cases of pneumonia?
Not all cases. Uh, uh, Probably after 4 to 6 weeks of appropriate therapy to look for resolution. Uh,
Look for resolution how? Clinically, or what do you do?
Radiographically to look whether the size of the opacity has reduced,
Mhm.
whether there's clearing of the lung fields,
Okay.
and
So in
clinically,
this case, what would you do? You have given me two options: repeat radiograph or CT. What would you do?
um, I would probably patient is yeah, I would probably review this after 4 to 6 weeks of appropriate therapy.
Good. Okay. So the second case. Here you go. I'll give you a history. The patient is presented with a sensation of something in their throat.
Okay. Provided with a lateral cervical spine radiograph with a patient with a foreign body sensation in the throat. I'm looking closely at the vertebrae, and I can see a well-defined radiolucent opacity in the prevertebral soft tissue overlying C6 and C7 vertebra, which is forming a bulge on the posterior tracheal wall. So this is probably, I would ask for history of any foreign body accidental ingestion, or was there any?
The patient said that he was eating fruits and then felt something in the throat and could not, felt very uncomfortable and rushed to the A&E.
Okay, so probably this could be a seed which has been lodged there. So routinely, I would convey these findings immediately to the referring clinician. This is a foreign body and it needs to be removed. So probably I would also ask for some cross-sectional imaging with the CT to confirm my findings and take it further.
Do you need a cross-sectional imaging? What kind of cross-sectional imaging did you have in mind?
CT, probably to.
So do you think in this patient will have anything to gain through the extra radiation that a CT provides versus you just referring them to, I don't know, ENT to have it removed endoscopically?
Probably not.
Yeah.
I would suggest ENT referral and probably removal.
Yeah. Good. Okay. Next one.
Okay. Provided with a frontal chest radiograph of an adult, and I'm looking closely at the lung fields. I can see that the bones appear abnormal. They appear very tubular and of reduced density, appear widened. The lateral edges of the clavicles and also the ribs they appear a bit widened overall, and rest of the lung fields are clear. I can see some clips in the abdomen, probably cholecystectomy clips overlying the liver, and also some radio opacities overlying the stomach bubble. So I would ask for relevant history. And
before we go to the relevant history, two questions. So you described the bones. Can you tell me a bit more about what your thoughts about that are? And you mentioned the clips on the left upper quadrant. What do you think they are?
probably post-gastrectomy.
Okay. Anything else in that anatomical region that you can think?
Okay. Left upper quadrant. I can't make out the splenic shaft here clearly. And other possibility, kidney, maybe suprarenal.
Okay. So you can go back to the bone and continue how you're saying.
So there's a diffuse bone abnormality. So I don't see any definite lysis or aggressive bone lesions in general. So this could be either a metabolic kind of abnormality or more likely, and it's less likely to be like a more malignant process which is happening.
Okay. So when you say metabolic, what do you have in mind exactly?
Probably like a hyperparathyroidism.
Hypoparathyroidism, did you say?
Hyper,
right. Okay.
hyperparathyroidism. The reduced density, maybe some form of reduced calcium absorption issues, maybe. And so,
So if I were to show you this, will that help you? This?
okay, yeah, provided with the hand X-ray of the same patient. Yeah, there is significant subperiosteal bone resorption and overall decreased density.
You have other views. I'll just quickly show those to you if you think it can add something to you.
Okay. Okay. This. Okay. Yeah, I'm still stuck at a generalized bone disorder.
Okay, and you think apart from hyperparathyroidism, do you have any secondary differentials?
Probably sarcoidosis, but doesn't fit the.
Okay, no problem, no problem.
Yeah.
Let's go to that next one. So you have control, do you? Can you ask for control?
Yes. Okay. Yeah.
Sorry. Yeah, go ahead.
Okay. So I can just scroll with my.
Yeah, you can scroll
Yeah,
whatever
yeah.
way you want.
Okay, sure. Yeah, provided with an axial post-contrast lung CT in the lung window of an adult and reviewing the lung window images. I can see that there is an opacity, there is a filling defect in the left proximal pulmonary artery. This is an emergency, and I would inform this immediately. As soon as I see that, I'll probably review this in the normal soft tissue windows as well.
If you could just stop moving your mouse for 1 second, I'll make that available to you. You can go ahead.
Yeah, okay. I can see that, yes. Yeah, I can see that there is another filling defect in the right descending pulmonary artery as well. And also in the left large thrombus, saddle thrombus, in fact, involving the pulmonary artery. So this is an emergency, and I would convey this immediately to the referring clinician so that appropriate measures can be taken for the same. So routinely, I would ask for history of DVT if the patient has any predisposing coagulation disorders.
This patient does in fact have a previous history of DVT, which was seen on ultrasound, yes.
Okay, if that is the case, then this is pulmonary embolism secondary to migration of thrombus, and appropriate treatment can be initiated for the same.
Okay. So
yeah.
can you just let go of the mouse? I'll quickly show you the
Yes.
next one.
Yes, sir.
Yeah, go ahead.
Yeah, provided with MRI axial T. Okay, is this the T2 sections?
Are they?
Sorry, this is a gradient, I suppose.
Mm-hmm.
Gradient images of an adult brain.
Mm-hmm.
And I'm looking for, I can see that there is some fluid within the frontal sinuses.
Mm-hmm.
I am looking at the brain parenchyma closely to look for any obvious foci of blooming.
Mm-hmm.
I'm not seeing any evidences of any hemosiderin staining. I'm looking at the vessels now.
Okay.
I can
So
see
just to
yeah.
make you make it faster, I'm going to show you the other sequences.
Okay.
What would you like as the first sequence?
An axial T2.
An axial T2. Just can you let go of the mouse? Yeah.
Yep.
Yeah. Here you go.
Yeah. Provided with an axial T2 images. Yeah, I can see that there is the loss of flow void in the left ICA, suggesting left ICA thrombosis. So I would look for any infarcts in the left ICA territory. There are some hyperintensities in the left deep white matter. I don't see any large infarcts. I would review the diffusion weighted images as well routinely to look for any acute infarcts. I would look
If you let
closely.
go of the mouse, I'll just give those to you just because you asked for them.
Okay, yeah, I can see that there is high signal on diffusion weighted images. I would look at the ADC map as well. I can see that.
I can assure you, I can't show you the ADC, but I can assure you they were low on ADC. So
okay, so these are acute infarcts. They're probably secondary to the left ICA thrombosis. So in my routine practice, I would ask for any history of if any previous carotid Dopplers were done to look for any thrombi in the proximal vessels as well. And
no, they were not. So what do you do now?
so this is an emergency, it's an acute infarct. I would involve the neuro team and the neuro intervention team to treat the ICA thrombus.
Any other imaging that you can think of that you might like to do preoperatively to help them plan?
CT angiogram.
So we don't have a CT angiogram, but
Or
I
do
can
you
help
say
you. I can help you with the MR angiogram.
MR angiogram? Okay. Provided with MRA images, I can see that okay, there is complete occlusion of the left ICA all the way up to the visualized all the way. So complete visualized left ICA is occluded. However, I can see that there is cross flow from the other side, and the MCA is getting opacified
So
from the
you,
other
you've
side.
said all you need to say about this case. So we'll go to
Okay.
the next one. So I'll just start with this. What do you think?
Okay. Provided with the pediatric abdominal radiograph, there is some study which has been performed. I am not able to. I can see some contrast in the pelvis. This is okay. So this is probably some kind of MCU or okay. Okay. Looking at the radiograph in general, the bowel loops appear normal. I'm not seeing any abnormal free air. I can see that there is contrast in the collecting system bilaterally,
Mm-hmm.
and there is some contrast which is outlining the bladder.
Mm-hmm.
So I would ask for history in this case as
So this is
to
a young
why.
patient who presented with dribbling of urine, and the parents said they have some kind of abdominal wall problem.
Given the history, I'm thinking in case of some form of a body wall disorder, probably some kind of exomphalos or something of that sort. I'm looking at the spine closely to look for any dysraphisms.
Mm-hmm.
The lower sacral vertebrae is visualized, and there is grossly it looks okay. Um, Probably this was done as part of since if there's a bladder extrophy, probably this was done to evaluate the system, the collecting system, and the excretory system.
But what else do you see? I don't believe you have finished describing everything that you see.
Oh, and also the also
Okay, so the time is up.
Okay.
Okay, so Nikhil, should I start with the feedback for my
Yeah.
set of cases and then hand it over to you?
Sure, please.
Okay, cool. So we'll start with the first one. You did well to find the pathology very quickly. I guess you did say that the bilateral hilar were enlarged, but honestly, they're not. I mean, they look pretty symmetrical in size. There is no increased density to either of them. The contours look fine. So just make sure that you don't say things unless you absolutely mean them, right? Because if you were to think that the hilars were problematic here, then you would automatically go along the lines of tuberculosis, sarcoidosis, malignancy, and all that. Whereas this is actually a very simple case of pneumonia, right?
Okay.
And then you said CT. So again, you have to have a better understanding of how they do things in the NHS, and they're very conservative when they are ordering ionizing radiation. So if a patient does not need it, you don't order it. In this case, there are no features of atypical pneumonia. This is a simple pneumonia. It can be bacterial. Yes, that's more likely what it is. And then you just advise bacterial antiviral or antibacterial therapy, and then review after 6 to 8 weeks. If it's completely resolved on an X-ray, you don't need to do anything. In fact, in some trusts, they don't even order the review X-ray in an adult patient. They just, if the patient clinically improves, they don't do anything. So be very careful when you're ordering the next step if it involves ionizing radiation. Okay.
Okay.
Good. The next one, it was a relatively simpler case and you did really well. The only criticism I would say is when I gave you the history of the patient feels something in their throat and you did repeat that and said foreign body sensation, which was well done. Then you said, I'm looking at the bones. So I know you are looking at the bones, we all do, but make sure you don't say it out loud because the examiner expects you to prioritize, right? So you expect something in the soft tissues because of the history that the patient gave you. So you can describe what you find in the area that you expect something, and then you can move on to say, in my routine practice, these are my checklists and I look at them and they're absolutely normal. But make sure that you don't start with the structure where you don't expect to find something, especially given the history that you already have. Does that make sense?
Yes, it does. Thank
Okay.
you. Yeah.
This one was again, I was very happy that you picked up the finding very quickly, but then you didn't think of the common you did think of hyperparathyroidism, that is common, but what about anemia, right?
Okay.
Because you describe them really well. They're expanded, there is coursed trabecula, and it is a diffuse finding. And then you notice the clips everywhere. This is actually a splenectomy. So it's not very specific, but one of the signs that that are described for a splenectomy is that the shadow of the splenic flexure reaches right up to the left dome of the diaphragm. So although it's not very specific, if you counter with that, I will agree with you. But at least you know that there are clips here. So yeah, it could be kidney, but it's not gastrectomy. And especially given that you're looking at these kind of findings, you have to think about splenectomy first. Okay.
Okay.
So this was, and then I showed you this just to show you that the changes were in fact diffuse, and this coarse trabecula expanded bone, you can see it in the other bones as well.
Okay.
Cool. This one, I don't really have anything to add to it. You did well. The HRCT didn't have anything. You quickly spotted the abnormality anyway. You asked for the proper contrast phase and the proper windowing, and you found the finding. You considered the possible source. You talked about it. So well done. This is well done. This one, again, you spotted the finding quickly. I deliberately started with this. So because sometimes the examiners do that, just to see how you approach something that doesn't have a lot of findings. So you did what you should do. What you did, you just describe it, say you don't find anything that can be significant, and in your routine practice you would look at the other sequences, which is what you did, and the rest was absolutely correct. This is a complete left-sided ICA thrombosis with the relevant watershed infarcts in the typical regions that you would expect that to have. Finally, this one, yeah, this is where you fumbled a bit, I would say, because you saw this, you tried to describe the study, but you were not very comfortable doing it. And then I think you sort of distracted yourself from describing the whole thing. So you can see how there's an increased distance between what you would expect this symphysis to look like, right? And then you started describing the opacification of the collecting systems, the ureter, and then you would expect the bladder to be opacified, but it is not. So the diagnosis you reached, you reached it. It's actually a case of bladder exostrophy or ectopia vesicae, no matter what you call it, but you didn't describe it well enough. So the examiners, they want to see how you reach the diagnosis, because I gave you very suggestive history. So you clinically got there, but you didn't get there based on the correct steps that you would expect yourself to take, right?
Okay.
So this was, this is a bladder extrophy with the classic manta ray sign, which has been described, I think, in 2014 by one of the Radiopedia editors. And the rest, you looked at the other bones to look for any associated abnormality. There aren't really. The other thing I would ask you to be very careful about is when you describe them, this is an abdominal radiograph and this is a pelvic radiograph. So if you're not very sure what to call it, just say this is a radiograph in a pediatric patient showing the pelvis and the part of the lower part of the abdomen. That's it. Because sometimes, depending on where they cone down, how they sort of, what structure they include, the name changes. So that's something to think about.
Okay.
I'll just quickly go over to Nikhil's cases, and I mean, he can, I'll stop sharing, Nikhil. I'll just say a couple of stuff to him.
I think we have a question. So someone has asked,
Yeah.
do they order BAL or AFB routinely in consolidation cases in NHS?
Not routinely. If it's a simple cut and dry pneumonia, you just give the patient, you just refer the patient back to the GP. they'll give them some antibiotics, and then the patient gets better, it's done. You don't need to do anything. Why complicate something that's, that's a pretty routine pneumonia?
Right. Yeah. Dave, if you want to go ahead with my cases, you're more than welcome.
Uh, No, I just have one. What did I? Yeah, I just had to tell him that time. So when you started with the first radiograph that Nikhil gave you, you spent a lot of time describing things, especially in cases when you know that there is a very limited amount of information you can gather from a radiograph. Then I say that you describe it, give your list of differentials. Even if you're stuck, just mention that you want the CT and for what reason.
Okay.
Okay. Just be a little bit faster there, because you spend a lot of time, and obviously the examiner can choose to spend a lot of time. They can ask you questions about it, and there is nothing wrong with going through a fewer cases, because the examiner might choose to exhaustively question you about one case to see how well you can
Okay.
deal with them. But I want you to speed up a little bit, not in describing things, which you do in a very nice speed actually, but when you know there's not much to be gained, don't beat about the bush and talk about your review
Okay.
areas and
Okay.
that. Okay. All right. So Nikhil, you just go with your discussion.
Yeah.
I'll
Thanks.
deal with the chat. Yeah.
Right, right. So, personally, I felt you're a very strong candidate. The fact that you have a great fluency over your thoughts, you have always, in all the cases that you've described for me and for Dr. Dev, you have gone with the imaging findings, interpretations, management, and you've already always finished it till the management, and then you have let me speak about the case. So that's something which I like about your description. The only thing I might give as an advice is avoid using short forms. I think in that case of ICA thrombosis, I think you repeatedly said ICA. I would prefer if you had used the full form. And in case of
Okay.
pulmonary embolism, I would have, I think the examiner would be happy if you just mention about the right ventricular strain, if it is present or not, because that would always be a good way to end that case, right? So coming to
Okay.
my case,
Yes.
I think to be honest, all the cases I showed to you were a bit on the difficulty level, and this finding was quite difficult to be picked up on the anteroposterior radiograph. But you were very quick to even pick up a subtle finding. So, but then here you can see a faint a calcification, but then it's very hard to pick on AP. But in lateral, you picked up very quickly. You gave me a very good set of differentials. I would have wished you spoke about the aneurysm of the coronary artery, since you spoke about the left ventricle as well. But having said that, you were right about the management. You were right about going for CT, and further down. The only reason I kept questioning you was because you were doing well in the case. So I think this happens in the real exam as well. The more questions you are asked in depth, that means you're doing well in the case. Just to answer the few questions that I had asked, in pseudoaneurysm, the neck is narrow, and in the true aneurysm, the neck is wide, and the three layers are seen in true, and there is only one layer seen in false. False is more worrisome, so you need to intervene quickly, right? And coming to ectasia, it will be 1.5 times the dilatation, and you will have length of more than 50% of the total length of the coronary artery for ectasia to be called in. Okay. So with that
Okay.
case, we go to the next one. In this case, you picked up the implants, which is good. So in this case, the implant is calcified on the right side. I wished you had picked up the right side aortic arch a little earlier. So there was even the gastric shadow is to the opposite side, so it is situs inversus. The fact that there is additional findings where you're seeing an opacity here in the left hilum with few reticular markings. So this was a case of a recurrence with breast implant, which was seen in the left hilar region with lymphangitis carcinomatosis. Okay. So I understand there are multiple findings here in this case. So just this case would be more than enough for an examiner to assess how your concepts are, how you observe, how observant are you, and if you had picked up this was an aortic arch and if this was a lesion, then I would have asked you where would you place it? Would it be an anterior, posterior, mediastinal mass, and so on. So I think the discussion would have gone those along those lines. But then, having said that, I think you handled this case well. This was lines and tubes and implants are very common in exams, as I can as you understand. So this was a case of a contraceptive implant, which is often seen placed in the forearm of a non-dominant hand in females. Okay, and these are mostly placed in the subcutaneous plane, as you can see in this radiograph. Oftentimes, they are coated with barium sulfate so that they are very radio opaque and you can see through them. Okay. And what we do is most of the times when the patient palpates and does not feel it, often they go to the gynecologist and then radiograph. We image it so that has it migrated or has it gone deeper down. That's the whole point of imaging such contraceptive implants. And also remember that we replace these implants every 3 years. So that is something you should always remember. That such questions can do come up in the exams. Okay. So I think I had shown you these three cases, I assume. And I personally feel you have done all the all the cases that I showed, and as well as Dr. Dev showed well, except for one case which is expected in real exam as well. In totality, I think you saw around 7 to 8 cases in a single room, which I feel is good. I would definitely think you would get a 6.5 on total for all the cases that you have seen and discussed. Yeah.
Yeah, I would agree with you. Yeah, 6 to 6.5 sounds good. Yeah.
Yeah.
Okay.
You'll get a you'll get a detailed breakdown of the whole thing from us via email. Don't worry about that.
Yeah. And do you have any questions for us?
No, I mean, in the first case, is it like how do we close that case quicker? Like I was sidetracked by the fact that there was some
no, I
surgery
totally
going on.
understand. I chose to go extensive because you can see all different types of examiners. Some people go. I personally got one examiner who was very extensive, and I got to see only 3 cases. Um,
Okay.
and on the other room, I found examiner was like someone like Dr. Dev who went very quickly from one case to another. So in this case, like Dev said, if you're not able to see anything specific, you would say that this is the limited things that I can say on this radiograph. I would like to go for the lateral, and then you could go to the lateral and say that these are my differentials. This is what I would like to convey, and I would say a conditional differential would be a better approach here. If this patient had a recent history of MI in recent past, I would think along the lines of left ventricular aneurysm, which would have chronically calcified. And if this is an incidental finding, I would also think of a pericardial cyst, which has also calcified. In which case, I would definitely inform the findings to referring physician, and I would take the next step. So I think I wouldn't say you were not speeding up. I just chose to like check your knowledge extensively. But otherwise, I think your speed was very good. Yeah.
Yeah, I mean, that was the point. See, I went fast and Nikhil went slow. You can get all types of examiners. Different people have very different styles of, interrogating your knowledge. So be prepared for both types.
Correct.
All right. Thank you. Thank you.
Thank you so much for being with us.
Oh, thank you so
I
much.
think, Dr. Dev, we'll wind it up. Probably we take the next candidate in the next session. It's already 9.
Yeah. So yeah, let's quickly go over to the next session. I was just replying to some of the.
Sure. Any final questions for us in the chats, please? I'll just go through the chats. Okay, shouldn't we also consider bronchoalveolar carcinoma in a periphery located consolidation?
I've replied to that, and I think Varsha was asking why I said I didn't say rush through. I said when you know that there is no other findings, because he was describing the normals more. That's when I said you can just sort of wrap it up quickly after you've described the abnormality, and then ask for the next step instead of taking longer to just describe your checklist areas.
Right. So
I think Shabib has a few questions. I didn't understand what he wanted to know exactly.
Can you show the frontal view of the implant case? Okay.
So yeah, this is one of the most complicated cases in radiopathology. I would say I've done a post on this a couple of years back. So yeah, the second one that you showed, I think this were bilateral implants with previous history of breast carcinoma, and this patient had lymphangitic carcinomatosis as well on the left. That one, the paratracheal.
Yes. I personally love that case because
I know it's a very hard case.
it's a very hard case and it can really test your knowledge
Absolutely.
at multiple levels. So I think the fact that if there is an opacity here now, you were to think, is it an anterior posterior mediastinal mass, right? So the
Yeah.
fact that it's right-sided aortic arch, this happens to be ascending aorta. So since the ascending aorta is seen, this opacity becomes a posterior mediastinal mass, which can completely throw you off track if you don't pick up the aortic arch. So that way, I think this is a very good testing case to test your knowledge on X-ray. So be aware of these such kind of cases in the real exam as well.
Okay, is candidate 2 ready? Can we start then?
Yeah, that's what I was thinking. Shall we do it next session, Dev? I mean, next time, because I think it's already 9. Might take another half an hour.
That I mean,
Do you want to
I'm
do
okay with it. It depends on you.
is candidate 2 okay with
Is it okay with we might overshoot by 15 minutes in the first session, timing issues, but if you're okay with it, candidate 2, we're good. The examiners are good. It's up to you.
No, we can continue.
Sure.
Okay.
Great. Okay, fine. So Dev, why don't you start this time? I'll go for the next
Okay. Okay. Got it. Yeah. Give me one moment,
I'll just
please.
stop sharing one second. I'll stop sharing.
Sure. Yep. The timer is ready and can you see the screen?
Yes, I can see the screen.
Good to go.
Okay, I've been provided with X-ray of the hand front, a PA view of a skeletally mature patient. I can see that there is diffusely increased thickening of the subcutaneous tissue, which is diffusely involving the whole of the hand, and the underlying bones. They also show the smooth periosteal thickening, and the with cosine trabeculae and some patchy areas of osteopenia. Apart from that, rest of the lower end of the radius ulna appears normal. The carpal bones appears normal. There's no evidence of any erosion or any lytic or sclerotic lesion, and there's no evidence in any obvious bone destruction. So to conclude, there's evidence of diffuse soft tissue thickening with diffuse smooth periosteal reaction, which is involving especially the metacarpals and all the phalanges. These findings are suggestive of thyroid acropathy. In my routine, I would like to see the previous x-rays of the patient, check the patient clinical history, see the thyroid hormones, the thyroid profile, and refer this patient to the endocrinology department and discuss this in the endocrine MDT discussion for further management. Thank you.
Okay. Second case.
I've been provided with X-ray chest frontal view of a skeletally mature patient. I could see that there is evidence of a pacemaker. However, I'm not able to see the lower ends of the leads to see whether it is properly placed or not. In my routine practice, I'll adjust the brightness of the image. Apart from that, I can see there's a complete opaque hemithorax on the left side, but there is no evidence of any mediastinal shift, either to the ipsilateral side or on the contralateral side. The visualized right lung appears normal. Coming to the heart, the border of the heart is seen. However, the left border of the heart is not seen. The right hemidiaphragm appears normal, where the left hemidiaphragm appears obscured, and the bones appears normal, visualized bones except the left-sided ribs, which is not seen. So there's evidence of a left opaque hemithorax. This could be because of there could be a combination of effusion with there could be effusion with collapse on the left side, which is because of which there is no mediastinal shift. Apart from that, the other finding could be a large left-sided mass, which could be a left lung mass, which is causing collapse of the lung. But again, there is no mediastinal shift. And other differential could be yes, these would be my differential. Could be a mass or could be a pleural effusion with underlying collapse consolidation of the left lung. And I'll convey these findings to the respiratory team and see the previous X-rays of the patient and suggest a CCT thorax for further evaluation.
Before you ask for the previous X-rays, is there any other differential apart from the ones that you have mentioned? Can you think of anything else to add to that list?
There could be a large pleural effusion. However, there is no opposite mediastinal shift, or there could be only left lung consolidation. So there's no mediastinal shift.
What if I were to tell you that this patient is long-term patient of the hospital, has had surgery and has been on follow-up for the last couple of years?
This uh, could be a case of a pneumectomy or any could be some case of the surgery or any surgery of the left lung, resection maybe. And for any chronic previous ILD or any previous chronic disease for
Would
which
you
the patient.
expect a surgery for ILD to involve only one lung?
No, maybe I cannot see any lung rib changes, but it could be probable that the right side appears normal because the right side could be a transplant lung. But however, I cannot see any rib changes on the right side.
Okay, it's okay. We'll go on to the next one.
I've been provided with X-ray abdomen and pelvis of a skeletally mature patient. At the first glance, I can see there is diffuse osteopenia of the bone. There is a prosthetic right hip implant. The left hip joint appears normal. Uh, Coming to the iliac bones appears normal. The bilateral SI joint, so on the right side there is mild reduction. However, I think it is projectional. The vertebra shows decreased density. However, no obvious areas of sclerosic or lytic destruction is seen. Coming to the abdomen, there is multiple scattered areas of calcification which is seen even in the pelvic cavity, the right lower abdominal wall, as well right lower abdomen, as well as in the left upper hypochondrium. And apart from that, no obvious opacity I can see, and few dilated prominent bowel loops could be seen in the central abdomen, and no evidence of any obvious pneumothorax is seen. So to conclude, the only finding I could see was some prominent small bowel loops and scattered areas of calcific density within the abdomen. These findings could be because of any uh, s- uh, these could be because of secondary hyperparathyroidism, or these could be because of some tubercular peritonitis, or like in case of sclerosing peritonitis with some cocoon formation, or these calcifications could be because of some and the lower calcification in the pelvic cavity could be because of a UB calculus. In my routine practice, I like to see the previous x-rays of the patient and for comparison for these calcifications. And I'd suggest CCT of the abdomen for further evaluation. And I'll refer this patient to in the gastroenterology MDT discussion.
Okay, so before we go on to to CT or something else, what are your review areas in an abdominal X-ray?
My review areas would be under the diaphragm, which there's no air under the diaphragm. And however, I could see one linear gas-like structure with it overlying the right lever, which is central in location. Okay. So it could be a pneumobilia, and the calculus which is seen in the pelvic cavity, that could be some displaced GB calculus. So I'm thinking maybe this is a regular stride, or it could be gallstone ileus. And as there's also a small bowel dilatation is also there, so this I think is a gallbladder gallstone ileus. I'll convey these findings to a referring clinician and suggest a CCT to look for the ectopic stone and the cholecystoduodenal fistula, and refer the patient immediately
You can
to the
ask for
gastroenterologist.
control. You can ask for control, and you can try looking at the CT. Yes.
Yes, I've
Go
been
ahead.
1 second, I'll try scroll. Yes, I can scroll through it. I've been provided with the abdomen. I'll just scroll through them before I start describing the findings. So at the first thing I could see there is pneumobilia, with the air lucentia centrally located, and there's also air within the gallbladder, and there's some evidence of a cholecystoduodenal fistula at this level. As I'm going down, I'm looking to I'm searching for any gallbladder stone. there's a small ventral umbilical hernia which appears not uncomplicated. So in the terminal ileal loop, I could see there's evidence of the calculus, which is ectopically placed, and proximal to this, the small bowel loops are dilated with air fluid levels within. So as this is an emergency situation, there are few non-specific calcification which are also seen
You
in the
can ignore
abdominal.
them. You can ignore those. You can ignore
Those
those.
can be phlebolytics. So I'll pick up the call and convey these findings to the gastroenterology team, as the patient may need emergency surgical for the removal of the calculus, as it is obstruction. And however, the bowel loops wall appears normal, and there's no evidence of any pneumoperitoneum.
Okay, can you let go of the mouse, please? Thank you. Next case, yeah.
Okay. I've been provided with a CT axial section of the pelvis. I could see that in the region of the sacrum, there is a large soft tissue opacity, heterogeneously enhancing soft tissue opacity with few areas of fixation within, which is probably arising from the sacrum
Just to
on the
remind you, there's
left
the
side.
last 5-minute warning. Go ahead.
Okay, so this is causing a destruction of the underlying sacrum as well. And the rest of the bowel loops and the bones appears normal. So I'm thinking as it is a heterogeneously enhancing mass uprising from the sacrum with areas of calcification within, my first differential would be a neoplastic mass like a chordoma, or in other differential could be chondrosarcoma, and third differential could be any GCT. However, my first differential is a chordoma. I'll convey these findings to the referring clinician, and refer this patient to the secondary bone center, and the patient should get a CT chest, abdomen, pelvis to look for staging, bone scan to look for any metastasis, and by a bone specialist we should get a CT guided biopsy of the lesion for confirmation. Thank you.
Before we go on to all of that, in your routine practice, do you when you were starting with an axial, yeah, what else do you do?
To look, I'll also get an MRI of the pelvis to look for the local.
No, I'm not asking about the next step. When you're looking at this study and you have the axial section.
I'll also, yeah, I want to look at the bone window as well.
So I will give you the bone window.
Okay, this is the axial bone window section. I could see the mass is arising from the sacrum, and there is a lytic disc-ruction, and the mass is also extending probably into the left sacral foramina. So, sacral foramina, and so my differentials would be first of a chordoma. Second could be any
Do the bones look, I'm sorry for interrupting. Do the bones look normal to you?
No, all the bones diffusely appears thickened, and there's altered this trabecular pattern appear cosine. So this patient may be a case of a Paget's disease. In that case, this could be a osteosarcoma as well, and occurring in an aged patient. And so I'll keep osteosarcoma as first. And if the patient has, I'll take history of the patient. The patient has thalassemia. This could be a extramedullary hematopoiesis in the sacrum region.
So,
and third, I'll keep
if I were to ask you to choose between the last two differentials that you just mentioned, which one would you favor over the other?
First, I'll keep as extramedullary hematopoiesis. Secondary would be any sacral related bone tumors.
Okay, so what would be the next step?
I'll convey these findings and discuss in the orthopedic team, and suggest a CT guided biopsy of the lesion for confirmation, and also see the CT of the chest and abdomen to look for any other sites of extramedullary hematopoiesis.
You did ask for the MRI, so I'll just give you the MRI as well, because you asked for it before this, so you can take a look at the MRI. This is I can give you an axial section if that's what you want.
Yes.
I'm sorry, this is an axial T fat set. You can try this, yeah.
Okay. I've been provided with axial T1 images. there's evidence of a diffusely hypointense T1 hypointense mass, and
If you want to look for a specific sequence, you can ask me. I'll give that to you. If you think that's gonna help you.
can I look at T2 axial?
Sure. Just let go of the mouse. Yeah, take a look at the T2 axial.
Okay, it appears hypointense both on T1 and T2. And do we have FATSAT sequence?
You do. The first one was FATSAT. Yeah.
Okay, and do we have post contrast? It is appearing hypointense even on the FATSAT sequence.
Unfortunately, we don't have post contrast.
Okay, as the lesion is appearing hypointense on all the signal, on both on T1 and T2. So
Unfortunately, your time's up.
my
Okay,
differences remain the same. Like first
Remain
is
the same. That's
yeah.
okay. That's okay. So, Nikhil, do you want to take over?
Yeah, sure. Yeah.
Okay, cool. Just stop sharing. Yeah, go ahead.
Okay. Are you there with me, candidate B?
Yes, Nikhil.
Yeah. Okay. Yeah. This is your first case. Dev, can you? I'll keep the timer. Yeah. Go ahead. Yeah. Start the case.
I can start the timer. It's fine.
Yeah. Sure.
Can we zoom the chest
Sure,
X-ray a bit?
Sure. That's fine.
Okay. I've been provided with X-ray chest of a skeletally mature patient. I can see the bilateral lung fields appears normal. There's no pleural effusion, no pneumothorax. Hyla appears normal. Heart shadow appears normal. The visualized bones appear normal. The reps also appear normal. Looking at my review areas, they also appears normal. I could see there are some gallstones which is seen in the abdomen on the right side. Apart from that, I'm looking for any other abnormality. No evidence of any mass seen. There's no evidence of any volume loss. The vascular markings, bronchovascular markings also appears normal. No retrocardiac opacity. Can I check the apices also? I'm not able to see them.
Yeah. I'm so sorry.
Okay. Okay, so there's no pneumothorax, and the clavicles and the humerus and the scapula also appears normal. No obvious destruction. I'll check the ribs once again. So there's no rib notching and no lytic destruction I could see as such. And coming to the vertebrae, although I cannot see the pedicles of all of the vertebrae, however, no obvious destruction is seen. The aortic knuckle is also seen on the left side. Um, so on the chest X-ray, till now I haven't seen any abnormality. So do we have? I'll check the history of the patient for which the chest radiograph has been done, and also look at the lateral chest radiograph if available, and okay, I've been provided with the lateral radiograph of the same patient, in which I could see the heart shadow appears normal. In the retrosternal space, I cannot see any opacity. Coming to the vertebrae, still the vertebrae appears fairly grossly normal. I can't see any destruction within the pedicles and the posterior spinous process. And I can't see any mediastinal mass as well. Okay, as I couldn't find any abnormality.
So why? Can you look at the spine one more time for me and tell me if there is anything abnormal in the spine?
Okay. Checking. Okay. Okay. I'll retract my statements. I can see there's H-shaped appearance of the thoracic spine vertebrae, and there's notching of the superior inferior end planes. So this may be a case of sickle cell anemia. I'll also see other features of sickle cell anemia if I could see. Yes, I did see the gallbladder stones. I'll check whether I could see the splenic shadow. Splenic. I'm not sure, but maybe the spleen appears small in size and is calcified, maybe, which could be a sign of autosplenectomy. And I'll also check the rest, the heart, for any cardiomegaly which is not there, any opacities within the heart, within the lung piece, which is also not there. And I'll check for any avascular necrosis of the humerus head. Uh, I have a no obvious sclerotic area I'm able to see on the right side, probably in the left humerus, which is doubtful. So this case is that of a sickle cell anemia, and I'll check the history of the patient, check previous radiograph of the patient, and if this is a new finding, I'll suggest workup of the patient and refer this patient to the hematological MDT discussion for further management.
What's the next case?
Okay, I've been provided with X-ray of a PA view of the left arm. I could see there's some tubular metallic density which is seen in the soft tissue of the arm, and apart from that, the underlying bones appears normal. So this could be some uh, this could be has been placed, maybe. I'll check any history of the patient for which this implant has been placed, and check previous x-rays of the patient if it was there, and take proper history. And this implant may be there to provide any um, long-term injections to the patient, or maybe any for administration of any drug, or this could be again a hormone, a device which could be which could be releasing hormone or any drug in this patient. And for this, I'll take proper history. I can't recollect the proper name of this implant, but I'll check the proper history of the patient for which it has been done.
This is the next case.
I've been provided. Can we zoom a bit?
Yep.
I've been provided with X-ray chest of a skeletally mature patient. In my first class, I can see there's a mild diffuse increased density of the bones. The bilateral lung fields appear normal, no pleural effusion, no pneumothorax. The heart shadow appears normal. Aortic knuckle is on the left side, no apical pneumothorax. The clavicles, humerus, and the scapula appears normal, no evidence of any erosion which is seen, and no obvious lung opacity I can see. All okay. So on the visualized vertebra also appears normal, and below the diaphragm, no abnormality I can see. I'll check my review areas once again. I'll check the ribs. Although there's increased density, uh, maybe there's some old fracture which is seen on the left side, left posterior seventh rib with some callus formation. Apart from that, I'm trying to see any, is there any retrocardiac opacity, which I'm not able to see. And uh, so my only findings is that of a this could be some metabolic bone disease, as I feel that there's increased sclerosis of the bones, and there was some old fracture. And I'll check the previous x-rays of the patient and take proper history of the patient, and evaluate the previous x-rays. And if I'll suggest a CT for further evaluation.
What are your differentials for increased bone density?
For increased bone density, it could be seen in osteopetrosis and myelofibrosis, for which I'll also see the spleen. If there is massive splenomegaly, there could be fluorosis, and there could be because of renal dystrophy. And I'll like to convey these differentials and check work. I'll do workup of the patient to narrow it down.
If I
And
say, if I tell you that this patient had a history of malignancy, what would you think of?
if the patient had a history of malignancy, um, mm, okay, if there's diffuse increase uptake, there could be sclerotic metastasis would also be my differential, for which I'll do a bone scan of the patient to look for other.
My question is, what are your thoughts? What are your differentials for a diffuse sclerotic metastasis?
Diffuse sclerotic, if this is adult male patient, my first differential would be a prostate mets. Others would be a breast malignancy, and others could be renal and thyroid. And in this patient, I'll check whether it is a male or female patient. I'm not sure, but I think there's breast shadow on the right side. However, it is not seen on the left side, so it could be a breast mets as well.
Okay. So we have a CT of the same patient. You could ask for control.
1 second. Requested.
Yeah. You can click and scroll.
Yes. I've been provided with CT axial section. I'll just scroll through them before I start describing my findings. So there's gross ascites. The liver spleen also appears enlarged. Pancreas appears normal. The kidneys appears normal. And the bowel loops appears normal. Apart, there's gross ascites and there's hepatosplenomegaly. I'll check the bone window to see whether there's widespread sclerosis, which was suspected on the chest X-ray.
You can click and scroll.
So I could see again there's diffuse sclerosis of the bones, and there's hepatosplenomegaly. So the causes of increased sclerosis with hepatosplenomegaly could be a CML, and it could be any lymphoma, leukemia, and myelofibrosis, although there is no massive splenomegaly in this case. And these would be my and lastly, there would be differential would be a sclerotic metastasis. So I'll provide these differentials to the referring clinician and suggest a follow-up. I'll review the previous x-rays and investigations if it has been done.
If I tell you that this patient had a history of urticaria and malabsorption, would you think of anything?
In case of urticaria, malabsorption, I'm not able to think right now.
No problem, no problem. We'll go to your next case. You can leave the mouse.
Yes.
Yeah, so this is your next case.
Okay, can we zoom?
Yeah, sure. One second.
Okay, I've been provided with X-ray chest of a skeletally mature patient. At the first glance, I could see there are multiple tiny innumerable nodules which are scattered in bilateral lung fields. The volume of the lung appears normal. The heart appears normal, no pleural effusion, no pneumothorax. Heart appears normal, ribs appears normal, and rest of the bones appears normal. So my only findings in this case is the presence of multiple tiny nodules which are scattered throughout the lungs fields in random distribution. So in this case, my first differential would be infection. It could be miliary TB. Second could be any miliary metastasis. Third could be varicella infection, in which case there would appear to be more calcified. And these would be my 3 differential. I'll check the history of the patient. If the patient has any history of TB before, any history of fever is there. And for TB, I'll suggest a tubercular workup of the patient, a sputum culture for further evaluation, and to check any previous test, X-ray or CT test which has been done. For miliary mets, I'll check the previous investigation to look if the patient had any primary history of any malignancy. And for these, I'll refer this patient to the respiratory team.
I'm sorry to interrupt. What malignancies are you thinking of when you think of
Uh,
cases?
for miliary metastasis would be seen in case of renal, lung, and thyroid. These primary can cause miliary mets as well.
So if I tell you that this is patient same images, and the patient is undergoing treatment currently for this.
Okay. This is an axial post contrast of the pelvis CT scan, which shows there's evidence of a polypoidal density, which is which is intraluminal in location, and which is protruding within the urinary bladder, and it is closely related to the right vesico-ureteric junction. This looks like a bladder carcinoma. And in my routine practice, I'll do a proper CT and stage this carcinoma. And so in this case, the case was of a UB carcinoma, which was causing miliary metastasis in the lung.
So
So I'll
are you sure urinary bladder malignancies causes miliary metastasis?
no, they don't cause.
So what do you think? I gave you a history that this patient is undergoing treatment for this. Can you connect the dots and
Oh,
tell me what could be the possible reason?
so still the patient is undergoing treatment because of this, and
Yeah.
so the patient is in immunocompromised state, so that could cause miliary
I'm sorry,
TB.
guys, the time is up.
Okay.
Uh,
Yeah.
so miliary TB would be my differential provisional diagnosis.
Thank you so much. Thank you so much. Yeah. I'll just quickly go through my cases first. We'll go through this first case. This is so all the cases that I gave you are purely discussion cases just to test your set of differentials. Okay, and you have done fairly well. Your flow of thoughts based on your differentials were good. I would appreciate that you start describe. Let's say you say miliary metastasis, then you automatically say that I would think along the lines of thyroid malignancy renal. You don't have to wait for the examiner to tell you what are you thinking of if you say miliary mets, correct? So you could speak. Am I audible? Are you there?
Yes, Nikhil.
Yeah, yeah. So you could say that, okay. And I think your description was good. Your speed is good, and you summarized the case well as well. The fact that I'm asking you this case was because very commonly we use intravesical BCG vaccination for transitional cell carcinomas. Okay, and there is an entity called BCGiosis. Okay, where
Okay.
a BCGiosis is a condition where you see miliary nodules in the lungs in patients where you give intravesical BCG vaccinations for transitional carcinoma of the urinary bladder. Okay, the whole point is not for you to diagnose that, but to know that such an entity exists. Okay, so
Okay.
when you're giving a differentials of miliary nodules, and if you're given a similar case scenario where you see a transitional cell carcinomas, and if they give you a history that a treatment was given to it, think of BCGiosis. Okay, so that was that case, and then I think I showed you this case. You again, your different set of differentials were good. Your approach was good. When you were given a CT, you again concised it to tell me a combination of diffuse sclerosis with hepatosplenomegaly. Okay. The fact that there is urticaria and malabsorption should make you think of mastocytosis also. Okay, a very common differential for diffuse sclerosis of the bones. Otherwise, you were spot on giving me a good set of differentials for diffuse sclerosis. Okay, so I was just pushing you to give the final diagnosis. Got it? So
Okay.
yeah, so I think that was it. And what was the other case? Yeah, this case I think H-shaped vertebra. I had to push you a bit to pick up that finding. So whenever you see gallstones, please always keep in back of the mind to look at the bones well. Actually, if you look here in the AP view, you would see the end plate is mildly curved here, is it? Even at this level, if you look, and if you had, if you, even the sag, the edge shape is quite evident at this level and even at this level, correct?
Yes.
Yeah, so these are very straightforward cases and they expect you to pick up these findings. So please don't fumble in these cases. Having said that, you picked up once I directed you to the direct direction. So you did pass this case like other cases, but then I would have expected you to.
I'll just interrupt, Nikhil. But can
Yeah.
you go back to that first case that you just showed her? Yeah, in this case, I noticed a couple of things which you have to remember during the exam. Go back to the frontal. So if you remember when the examiner gave you this case, he sort of scrolled downwards to focus on the infradiaphragmatic part, and then you asked for the apical part. So whenever the examiner is doing something, anything really, that usually has a purpose. So in this case, he wanted to make sure that that part is covered. And if you had noticed that particular finding before, then you would have started connecting the dots sooner. So I understand the apex is a review area, very important one. But if the examiner is giving you an unusual window or a slightly cropped up area, then worry about what's outside that area a bit later. But first, make sure that whatever he has shown or given you, you've exhausted all possibilities there. Secondly, especially in chest X-rays for this particular exam, try to have a sort of, what do you call it, a pathology best checklist, right? So make sure that there is no pneumothorax, there is no pneumopericardium, no pneumomediastinum. And if I'm looking at the vertebra, is there evidence of sickle cell? So specifically think about those diseases because they're very common and routinely tested, and make sure that in a list of 5-6 diseases that are the most common, those are not there, and then you can move on and think about the other things. So these are the two, I think, important points that I thought about when he was showing you this case.
Yeah.
Okay.
Yeah. Thank you, Dave. Yeah, I think I'm done with the case. I think.
Okay, so I'll just quickly share my.
There was one implant, Nikhil.
Right. Yeah.
Oh yeah, implant cases. Yeah.
This. So I understand this. You might have not seen earlier. This is called a transcutaneous glucose monitoring device. Okay. Very commonly used in diabetic patients to monitor glucose. Oftentimes, these implants we screen to see if the leads are in place or if it has migrated. So just keep a list of all the lines and tubes and implants that you see routinely. And so this was a case of transcutaneous glucose implant monitor. Okay. Yeah.
Okay.
Yeah. So I think I'll stop sharing, Dave. You can.
Yeah, I'll share my screen. Yeah. So yeah, this was the first case, right?
Yes.
Again, very well done with this case. I have nothing to say. Your speed was good. You got the diagnosis straight away. You talked about the differentials. The only thing I would say is there was one throwaway remark you made about coarse trabecula. So when you know that this is a case of thyroid acropathy, coarse trabecula, I mean, you could argue, but it's not exactly very typical of that. When you say that, you're sort of thinking about Paget's, thinking about anemia, that stuff. So if you're not seeing a lot of coarse trabecula, don't mention it. It's not a big point. You will easily score more than 7 on this case, if not 7.5 or 8. But just that one little thing that I noticed. Second case was this, right? So yeah, this it took your time to get to pneumonectomy. So this is a case of pneumonectomy, and you mentioned that there was no mediastinal shift. However, I would disagree with you. If you trace the trachea, you'll find that the lower end of the trachea is more to the left than to the right. So complete whiteout left lung. The other differentials you did cover, but this is a case of left-sided pneumonectomy with due to a previous right lung cancer. And you mentioned the pacemaker correctly positioned, no problem. But there are no other findings, but you have to sort of explore that possibility and consider it and talk about why you think it is that or not that. Okay. You did get there once I gave you the history. So in this case, it would probably be a 5.5. Okay. Just I'm letting you know the little things about each case. This one, which was this? Oh yeah, this one. So with the radiograph, you needed a little bit of help with finding this, but once I asked you about your review areas, you got there on your own. So you did not need help. You just took a little bit time. One important thing here, when you started describing the calcifications, you used a specific word called scattered calcific densities. And immediately once you use those words, you did start thinking about, abdominal cocoon formation or sclerosing peritonitis. And you sort of took yourself in a very different
direction.
yeah, different direction. These are not what you would describe as a scattered calcific density. In fact, there's a couple of nice cases on Radiopedia. Make sure you I'm sure you've seen them, because if that was your first thought, then you have seen those cases. So just make sure that you use the correct words, because these are kind of well-defined, lobulated, non-specific calcification, not that. And these are, I think, at the anterior end of the ribs. Not sure what these are. This could be something else as well. Again, non-specific. But yeah, other than that, you did well. You went through the management well. You did the CT very well. It's well done. This was a 6.5. This one it's kind of a tricky case, I agree, but with some help, you got there. So the only thing that would have helped you understand what this is the fact that the bones are all abnormal, even the vertebra, the entirety of the pelvis, and the proximal femur as well. So this is a case of extra medullary hematopoiesis secondary to chronic anemia. It can be anything. It can be thalassemia. In this case, it is thalassemia, or for whatever reason. You did say chordoma. Again, chordoma can be a possibility, but you would expect it to be high signal on T2, right? Because of the presence of the physalliferous cells. I think that's the pathological term, with I think mucin content, which leads to a high T2 signal, but it was completely hypointense on all sequences. I don't think we reached up to this case now. Yeah. So yeah, so you covered 4 cases and I think 6 to 7 modalities. So well done. You're right on track. Just practice going through more cases. That's it. That's all you need, really.
Yeah, I think I also agree with you. I think you're really a very strong candidate, and I think you're going on the right track. Your speed is good, your fluency is good. Keep practicing more and more, and see more cases. I think that would be enough. That would be my advice as well. Yeah.
Yeah, I mean, in this case specifically, you just make sure that you ask for. So I used to plan my preparation like this. Whenever I'm seeing a CT or any case, really, I would make sure that before I conclude that case, I would think about, is there any other projection, other sequence, other phase that I can think about, which I would routinely review in my normal practice. So if there are, in these cases, a bone window or a sagittal recon, then I would specifically ask the examiner, especially if it's relevant and it can change the diagnosis, to make sure you always think to yourself, is there anything else I can ask for? If the answer is no, very good, go ahead. If there is, make sure you ask for that, because they would appreciate that, you have a good normal practice and you want to sort of replicate that under exam conditions.
Yeah. Thank you, Dr. Priya. Do you have any questions for us?
Let me just quickly check the chat. Are there any questions here?
Dr. Priya, do you have any questions?
No questions. Thank you, Nikhil. Thank you, Dr. Dev.
Thank you so
Yep,
much.
yep.
Thank you so much.
Yeah.
Thank you, everyone, for attending. I hope this was, helpful to you.
Absolutely. Please feel free to ask questions in the Telegram group as well if you have any doubts.
Yeah. We overshot the time a bit, but we can answer your questions on Telegram. Yeah.
Absolutely. And if you guys wish to participate in the next sessions, please let us know. We'll keep updating the list of volunteers. Okay.
Thank you, guys. Thanks.
Until then, thank you so much for participating.
Thank you.
Thank you for showing us at good cases. Thank you.
Sure. All the best, everyone.
Thank you.